For the lessons this week, we're going to focus on home care and alternative settings. First, we're going to talk about a little bit of the history about how all this came into being and why reimbursement is so strict and tough. Well, it all started back in 1997 with the Balanced Budget Act, also called BBA. It had an impact on healthcare reimbursement. And what happened was it started reducing the payments to the durable medical equipment, which we also call DME. You'll hear that name a lot in the hospital in the subacute and LTEC settings. So they reduced the payments to the DME companies, home care agencies, and other alternative devices that are used for home. So despite this reduction, approximately 10 million Americans continue to receive home care at home in 2007, despite the reductions, and it still costs a lot of money, approximately $50 million. What we're finding is it is necessary to have other alternative ways to care for patients outside of the acute care setting. When we say acute care setting, we're referring to the hospital setting. So alternative care is the delivery of health care outside of the acute care setting. The following are examples of where alternative respiratory care to patients may be given. Now, when we say alternative settings, we're talking about non-acute care. So one of the areas is the long-term subacute care hospitals, also known as LTEC. The LTECs can deliver care similar to the acute care setting. The patient can go there for extended wean time, rehab, etc. And they can stay there approximately 20 to 30 days or maybe even a little longer if needed, if their insurance company would approve it. Also, an alternative would be the subacute care, and the subacute care is similar to like nursing home, but yet they can get still skilled care. A lot of our long-term vent patients that cannot get off of the ventilator go to subacute care for continual care. Home care is the most common. We have patients that go home with family or friends to be cared for, and they'll get medical supplies from the durable medical equipment companies. And then we have also the rehabilitation centers and the skilled nursing facilities. You'll also hear them called very frequently in the hospital SNFs. So by definition, LTECs, they provide highly focused care to patients with complex medical conditions. And this includes the ventilator and dependent patients that are having difficulty weaning. I love working at the LTEC. They have non-conventional ways to wean the patients, usually at a slower rate. But the LTECs are very successful at getting our ventilator patients off and to a trach collar, etc., and even decannulated. They employ highly experienced clinical staff, and this includes RTs, to provide integrated and interdisciplinary care. Some facilities use the latest equipment and specialized protocols. In the LTEC settings, the doctors only come around once or maybe a couple times a week, and they're very reliant on RTs to kind of manage the care as well as the hospital staff on nursing. Like I was saying before, the length of stay at a LTEC typically is 20 to 30 days, and it all depends on their insurance coverage and what insurance will allow. Most LTECs are for-profit organizations, so they're very dependent on funding. They do take in patients that have Medicare and Medicaid, but mostly private insurance is where they make the most money. Most patients will experience improvement because it is like a rehab type center. They are weaned from the ventilator. They have increased tolerance for ADLs. Most of the time, if the patient is able, they'll decannulate the trach in the LTEC. And then we also work hard at weaning the patient off of oxygen. According to the National Subacute Care Association, subacute care is a comprehensive level of inpatient care for stable patients who fall under the following: have experienced an acute event resulting from injury, illness, or exacerbation of disease processes, have a determined course of treatment, or require diagnostic or invasive procedures, but not those requiring acute care. So what are the goals of subacute care? Well, ideally is to apply intensive resources to stabilize patients after they've had a severe episode of illness. By definition, subacute care aims to restore the whole patient back to the highest practical level of function, ideally to that of self-care. So you want the patient to rehab or recover to the point they can take care of themselves. So in a subacute care, has a holistic approach requiring goal-oriented interdisciplinary team care, frequent assessment of progress, and a limited plan of care. So most of these alternative facilities always have like a RT, PT, nurse, doctor kind of working together to make sure they have a plan of care as to how they're going to get the patient back to their either their baseline level or back to functioning independently. The AARC defines respiratory home care as those specific forms of respiratory care provided in a patient's place of residence by personnel trained in respiratory care under medical supervision. And the primary goal when you're thinking of home care is to provide quality healthcare services to clients in the home care setting, thus minimizing their dependence on institutional care. So when we're looking at the home care setting, it's slightly different. Usually have patients that go home with inpatient rehab, or they're able to take care of themselves and maybe go to an outpatient or inpatient center just for continued care. And we want them to get back to the point that they can be self-sufficient and take care of themselves. But everything that we do is under medical supervision of the doctor. So when we're thinking of the objectives of home care, the objectives of home care is supporting and maintaining life. We want to improve the patient's physical, emotional, and social well-being. You know, patients seem to do better when they're at home in a comfortable and familiar environment. Promoting patient and family self-sufficiency, ensuring cost-effective delivery of care, and maximizing patient comfort near the end of life. A lot of times when a patient is near end of life, they go into what we call palliative care or hospice. And most of the time, they have everything they need through insurance. They very freely actually give equipment that's needed when it's end of life. But they will go home to the home care setting. A lot of patients prefer to, if they're going to pass on, die at home or surrounded by family and friends. So when we're thinking of patients that go home for care, what are these disorders, these pulmonary disorders that are treated by the RCPs that go out to treat the patients in the home care setting? So generally, the categories of chronic pulmonary disorders is chronic obstructive pulmonary disease, cystic fibrosis, which you see a lot, especially at the university hospital. They're at home and they do their own treatments. Chronic neuromuscular disorders, chronic restrictive disorders, and carcinomas of the lung, meaning cancer. Home care studies have shown that carefully selected treatment regimens can be of significant benefit to patients. So what are these benefits? These benefits include increased longevity, improved quality of life, increased functional performance, and reduction in the individual and social societal costs associated with hospitalization. When the patients go back to the hospital, it costs the hospital a lot of money. And now more recently, the government is kind of cracking down on frequent readmissions. If the patient is readmitted, I believe, in 48 hours or maybe 7 days of their discharge, they actually cut back on the hospital's reimbursement for care because they feel like they didn't resolve their problem initially before discharge. So what happens in a rehabilitation facility? Well, in a rehabilitation facility, they provide therapy and training for rehabilitation. We know that from our previous unit. The center may offer occupational therapy, physical therapy, vocational training, and special training such as speech therapy. They all work together for the benefit of the patient. The next category I'm going to talk about is skilled nursing facilities, also commonly called SNFs for short. A SNF is a type of nursing home recognized by the Medicare and Medicaid systems as meeting long-term health care needs for individuals who have the potential to function independently after a limited period of care. This also, in the SNFs, they have a multidisciplinary team that guides health care and rehabilitation services, including skilled nursing care. So the SNF is kind of a twofold thing. A SNF can have a rehab side, and they also can have the side where patients go there to live and function for every day. They can't go home. They need care from nursing. So they actually live there, and then they have another side of it where the patient gets rehab. So depending on the patient's need, when they go to the facility, it's the type of care they're going to get. So what are the benefits of the alternative care settings? Well, being in an alternative care setting can provide lower costs because it doesn't cost as much as it does in the acute care setting where you have the lab tests and tests going on and the doctors that are frequently rounding all those times that they go around to see the patient. They charge the patients for every time they walk into the room. The cost of the high-priced ventilators and blood work. So lower cost is definitely one of the main alternative reasons to send a patient home to subacute home care or LTAC. Also enhanced patient care compared with acute care facilities. For example, the LTAC They can get the same type of care, but you just don't have the high level of cost. Sometimes the downfall of being an alternative setting, especially a LTEC or a SNF, is the fact they don't get the same level of care as far as nursing. Sometimes they have more patients, especially in the SNF. The nurse may have 15 patients to oversee, or in a hospital setting, they may only have 5. So it definitely makes a difference. In this table here, table 55-1, it shows the major differences between traditional care setting and alternative settings for delivery of respiratory care services. It's definitely different from the acute care setting, which we consider the hospital, versus the alternative setting, which we look at long-term acute care, subacute, and home care. So when we're thinking about diagnostic testing in the acute care hospital, they can have inpatient testing via lab, x-ray, ABG analysis. Whereas you're looking at an alternative setting, they may use outside vendors to do diagnostic testings. They may ship their tests to an alternative site and have the results faxed over. Equipment support in a acute care setting, they have piped in O2 in the hospital, suction equipment where it may be more limited in the alternative setting. They may have to use a portable O2 tanks and suctioning systems. They don't always have all that high-tech stuff set up. Travel requirements, level of supervision. In the acute care setting, you have one facility and has direct supervision, whereas in an alternative setting, respiratory may have to work between several buildings. They have very minimal supervision. I've said to many students that in the LTEC setting where we work very independently and we call the doctor if we need anything because the doctors are rarely around. Patient assessment in the hospital setting, you have primarily the attending physician and residents, where in alternative care setting, we are very heavily dependent upon to do the care plan and relay it to the doctor. Documentation requirements and work schedule. Traditional acute care setting, limited to medical record keeping. They have specific hours. Where in an alternative setting, you kind of have to justify the things that you're doing, have ongoing follow-up, have very detailed financial record keeping. Work schedule, a lot of times you have to do on-call, etc. So all that stuff is set up at the facility. They have doctors that do on-call versus being available on site. Time constraints, patient-family interaction. In an acute care setting, more than one shift to deliver therapy. Limited time frame for treatment. You have little interaction. Where in an alternative setting, must complete all therapy during a visit or the shift. You have more one-on-one therapy, so that can be a benefit. Very intensive family interaction because you actually go into their home or their rehab room. And then when it comes to provider interaction in the acute care setting, you have the primary attending physician and nurses right there at bedside. But in an alternative care setting, you have a continuous interaction with all members and of the professional team because the facility is smaller and everybody's kind of right there on site. So there's very distinct differences between acute care versus alternative care. A lot of times in alternative care have more patients to take care of where you may not have as many in the acute care. Definitely differences, but I enjoy working in both. This is the end of section Unit 2, Section A.